Abdominal and pelvic trauma, a comprehensive approach based on advanced trauma life support guidelines. Welcome to the Everything Surgery podcast, where today we delve into the critical topic of abdominal and pelvic trauma, guided by the principles outlined in the Advanced Trauma Life Support Guidelines. Our aim is to provide a clear, systematic overview of how trauma teams approach these challenging injuries, emphasizing the importance of rapid identification and intervention to save lives. Let us begin by considering the foundational philosophy behind the management of abdominal and pelvic trauma. The process is highly structured, with the central question always at the forefront: does this patient require surgical intervention or specialized vascular procedures? And how urgent is the need? Hemorrhage is the most common cause of preventable death in these scenarios, and hollow organ perforation is another key concern. The entire management strategy is shaped by the patient's circulatory status. Abdominal trauma, assessment and immediate actions. The initial evaluation follows a systematic approach, prioritizing circulation and the search for life-threatening injuries. Upon inspection, practitioners look for wounds, abrasions, swelling, bruising, and specific signs such as discoloration around the umbilicus or flanks, as well as evidence of trauma from seat belts. Palpation is used to gauge tenderness, rigidity, and any instability, particularly in the pelvic region. While listening for bowel sounds may be performed, it is not a sensitive technique and should not delay more crucial interventions. The most urgent threats at this stage include massive internal bleeding due to injuries to solid organs like the liver and spleen, or major blood vessels, as well as pelvic fractures. Clinical signs that may signal such bleeding include low blood pressure, rapid heart rate, pale or cool skin, and swelling of the abdomen. If a patient does not respond to initial fluid or blood resuscitation, it is likely the source of bleeding is in the chest, abdomen, pelvis, or long bones. Rapid bedside ultrasound, known as focused assessment with sonography in trauma, or direct sampling of fluid from the abdominal cavity, help determine the next steps. If a patient is unstable and there is evidence of internal bleeding, immediate surgery is required and there is no time to wait for detailed imaging. In cases of organs protruding from the abdomen, the area should be covered with a sterile, moist dressing, and surgical intervention is indicated. Adjuncts and detailed assessment. Once the patient is stabilized, further investigations are performed to clarify the source and extent of injury. Focused bedside ultrasound is a quick, non-invasive method to detect blood accumulation in key areas of the abdomen and pelvis. Its advantages include speed and repeatability without exposure to radiation, though it is less useful for detecting injuries to hollow organs or injuries located behind the abdominal cavity. For patients who are stable, a negative ultrasound does not rule out injury, and cross-sectional imaging using computed tomography is often required. Computed tomography provides detailed information about solid organ injuries, retroperitoneal bleeding, and can reveal ongoing blood loss. However, the patient must be stable enough to undergo this scan. Direct sampling of peritoneal fluid, with or without washing, is now less commonly used thanks to advances in ultrasound and computed tomography, but may still be employed in specific cases where the diagnosis is unclear and the patient is unstable. The management algorithm is dictated by the patient's circulatory status. If the patient is unstable and there is evidence of internal bleeding, immediate surgery is performed. If the patient is stable, computed tomography can guide definitive diagnosis and allow for non-surgical management of certain organ injuries. For those who respond only temporarily to resuscitation, ongoing bleeding is suspected and advanced interventions or surgery may be necessary. Pelvic trauma, a vascular emergency. Pelvic fractures pose a significant risk for life-threatening bleeding following blunt trauma, and the guidelines emphasize that these injuries should be treated as vascular emergencies, not just bone injuries. During the initial survey, practitioners inspect and gently feel for instability, abnormal movement, and tenderness in the pelvis, taking care not to repeatedly manipulate the area in order to avoid disrupting clots and worsening bleeding. The primary threat in pelvic trauma is massive bleeding behind the abdominal cavity, arising from the fractured bone surfaces, veins, and occasionally arteries. The first step in management is to stabilize the pelvis and reduce its volume, which promotes clot formation and limits further bleeding. This is achieved by applying a pelvic binder or sheet wrap as early as possible, ideally in the field or during the initial hospital assessment. The binder should be positioned over the bony prominences of the upper thigh, not the abdomen, with the goal of closing the pelvic ring and stabilizing the area. Additional investigations include bedside ultrasound to check for internal bleeding, rapid pelvic X-rays to confirm fracture patterns, and computed tomography with contrast for stable patients to assess the injury in detail. Managing blood loss, abdomen or pelvis? A critical decision point arises when managing an unstable patient with a pelvic fracture. The results of the ultrasound examination guide further action. If both abdominal and pelvic bleeding are present, vascular procedures to temporarily block blood flow or immediate surgery may be required to control internal bleeding, followed by external stabilization of the pelvis. However, if the ultrasound is negative for abdominal bleeding, the focus remains on stabilizing the pelvis and performing targeted procedures to block arterial bleeding, rather than opening the abdominal cavity. Key principles for trauma management throughout the process. Circulatory status is the single most important factor in decision making. Unstable patients with suspected abdominal or pelvic bleeding require immediate intervention, not detailed imaging. Bedside ultrasound is a rapid triage tool to determine whether there is internal bleeding, particularly in unstable patients, while computed tomography is reserved for stable patients to guide non-surgical or targeted vascular management. Pelvic injuries should always be approached primarily as vascular emergencies, with early application of a pelvic binder. The question of whether the bleeding is in the abdomen or pelvis drives the management pathway for complex cases. By adhering to this structured approach, trauma teams can quickly identify and address life-threatening injuries in the abdomen and pelvis, ensuring that patients receive the appropriate life-saving interventions in a timely manner. Thank you for joining us on the Everything Surgery podcast. If you found this discussion informative, please like, share, and subscribe to stay updated on the extraordinary world of surgical care.